My topic is shortage of neurologists and eye gap in sub-Saharan Africa, the perspective of the World Federation of Neurology. So my name is Wolfgang Grisold. I'm the president of the World Federation of Neurology. Next, avanti. And we have presently 124 member societies scattered all around the world. Next, avanti. And I just made a screenshot from all the African countries, and you can see we have members West Africa, East Africa, Central Africa, North Africa, but still there's a lot to do that we have all members on board. Avanti. The trustees this year have duly formed. We have had an election and we have two new co-opted trustees. One is Dr. Minerva Lopez from Mexico, and the other person is Dr. Maria Benjabeli from Morocco, who were both selected to represent the regions. And we will have a new treasurer from the beginning of next year, which is Dr. Friedman. Avanti. So the World Federation of Neurology has several links that may be important for these considerations. We have a Global Neurology Alliance, which works with regions, with the specialty groups, with specialist or topical societies and world societies, Avanti. And Avanti, again, Avanti. And one of our great efforts are, in apart from the worldwide and global efforts, our educational programs. This is what we do in the moment. And I just want to point out on top left that our training courses are important, our training centers, and I'll speak about them in a minute. We have department visits, and there are many other educational aspects that we have. One that will be important also for the future is that we are planning a WFN American Academy leadership meeting for young neurologists from low or lower middle income countries to participate next year. Next, avanti. The other great achievement which we are working on, and this takes a lot of effort, is our connections with the WHO and with the United Nations ECOSOCs. In both societies, we are a non-state actor. So to just mention a few things from the WHO that are relevant for my talk. We know that the World Health Organization is promoting brain health, and these 5 topics are taken from a web presentation of the WHO, and that's free downloadable on how the WHO thinks brain health can be promoted. Avanti. And the one important thing that I'm going to come to in my talk too is the aspect of essential medicines. And the essential medicines reflect in their practicalities many problems that we have in the neurological presentation. The next one. What is in all our mind is the IGAP, the Intersectoral Global Action Plan for Epilepsy and Other Neurologic Disorders, which can be summarized in advocacy, treatment and care, prevention, innovation and research, and public health. And the fingerprint shows that it should produce a long-lasting effect. If you look to the right of that slide, you see a book from the WHO on the IGAP, which you can freely download. The next step, and this is important for all of us, is the formation of the toolkit of the WHO in regard to IGAP, which will be released in March, I heard today, and to which the World Federation contributed significantly in regard to the development. Avanti. The other important point that we have started last year, and there's more to come of that, are the United Nations ECOSOC. This is not a pure medical system, but it's aimed, and you all know the SDGs, to produce SDGs worldwide. And in particular here, they look at good health and well-being. Number 3 is one important thing, and this picture was taken in January when Professor Gocht and myself attended in New York. Next. Now, with all these preambles, I think we have to go into the details, and the topic is what do we think about the positions and about the personal coverage worldwide. First of all, we have the World Bank classification on the left side that we all know. It has become more politically correct, for reasons I don't know, to talk about the North-South gap. And if you want to read about that, there's a publication down there in the BMJ that explains that step. Avanti. Now, we also have done a very interesting survey that has been carried out for 2 years and has been mentioned at the World Congress, but it's still not completely finalized. And this divides the world into the social demographic index, which is from 0 to 0 in some countries, 0 to 750 in others, and up to 1 in some countries. And it's unfortunate because of the conversion, but you would see on that slide that the lowest income SDI is in 14 African countries. So 20 countries worldwide are in that lowest category, and 14 of them are in Africa. Next slide. So another marker I think that we implicitly discuss all the time is the question of life expectancy, and we can see that over the past decades, worldwide the life expectancy has increased, avanti. And I choose to compare life expectancy in Africa with life expectancy in Europe and the Americas. And you can see in particularly there's difference between Central America and Southern Africa and Europe and the United States.
Christy Kyle.
The next one. Avanti, please. So I was also looking at another significant data is, of course, the death rate per 100,000. And here I choose for this talk to compare the death rates of males and females from the United Nations, from the USA, and from Kenya. And you can see here in red on the left side, if you calculate for the United States, Alzheimer's disease and stroke are quite frequent and make 107 1 out of 100,000. And if you look at the right side at the African reports, you have HIV, AIDS, tuberculosis, malaria, which is less than here, but there's no sign of dementia. That means that this statistical data to support our actions are somewhat deficient, and this is one thing that we will have to work on. Next. There is, however, other reports, and this is from one of the talks in the WHO, that stroke, Alzheimer's disease, and Parkinson's disease are a leading cause of DALIs, as we know, and this has been reported in the wonderful reports that have been published on the GBD. Next one. Now, another point, I think another marker that we all know is their per capita income, and it's quite unbelievable, but that's how it is. If we look at territories like Kenya, Haiti, Zimbabwe, we can see the per capitum, in Latin would be correct, income is about $2,000 a year for each person of the country. If we look at the United States, we have about 80,000, and there are some European countries that even have more. This means that, of course, with 2,000 total income, it can hardly be expected that the country is able to contribute anything to the medical services, and other systems and other thoughts would have to be considered. Avanti. This is a very interesting paper, and you can see here the list, the quotation from the Lancet of Neurology by Dr. Fagin, who suggested in matching these problems that it would be a good idea to start with minimal neurologic services, essential neurologic services, and advanced services. And this is very much like what the Stroke Society recommends. Next. And if we look at the summaries and recommendations, I read out of this large, extensive paper, advocacy is important, government communication, which is IGAP. One thing, this is prevention. And you are the first group to hear it now because we have just decided the next World Brain Day of 2024, the topic will be brain health and prevention. And we think that prevention is terribly important. Of course, we have the size of the low-income countries, and we need to think of the collaborations. Next. Now, I tried to make three rather abstract seeming aspects to get closer to the problem. So if we look at the shop window, we see just the outside of the shop, and this would I say this is the number of neurologists that we discuss. If we go into the shop, we have transactions, people buy things, they negotiate, and this would be training, education, and updating in the sense of CME is very important. And then we have the black box of needs. Next. And for Africa, it's of course important to know how big is that black box, how many people are not treated by Western medicine and by other methods or other institutions. Next. So if we look from a bit further, we have to find the needs of the problem, we have to find the transaction, and we have to look at the number of neurologists. Avanti. And if we look at this picture, we know from the WHO data that Africa has 1.46 million inhabitants, a billion inhabitants. It has 0.12 neurologists per 100,000, but we do not know what kind of neurologists, health groups, and primary care there are. The World Federation has 7 training positions that train people and that we finance. Next. And if we look at that, this costs about $150,000 a year. If we had 10 times as much, it would be 1.4 million. And if it would be 700, it would be 14 million. So this is something that is difficult to attain, at least for the World Federation. But one important thing is that we think is important is to produce a core curriculum and empower the regions in training neurologists. And this can be more efficient than the individual training. Now, one more, next one. Now, if we look at this data, Africa has 1.4 billion, and if you look at this small, hardly readable table, you will see that there are some countries with no neurologists. We have heard that Africa globally has 0.12 neurologists per 100,000, and there are some countries like Switzerland, Germany, Austria, who have 13 neurologists per 100,000, which of course means that you will have a different spectrum. If you calculate now, I've already calculated the costs of increasing the training positions, but there's a different aspect that we also have to consider. Next one. And this is the related health groups. So neurologists alone, by calculating that formula, we could average, we have about 1,680 neurologists in Africa at present. If we would like to achieve what the WHO recommends, which is 1 per 100,000, we would need 14,000. But we would also need primary healthcare persons, we would need nurses and medical officers. Next. And it is quite difficult to find out what is the relation between doctors or specialists and the number of nurses and the number of medical doctors. I tried various sources, and the artificial intelligence told me where to look. I looked at them, but all these sources, I did not find any specific details. Next. So based on experience, we also always think when we speak about enlarging our work in neurology that we should delegate more to nurses and more to health personnel. This is wonderful, and I show you a slide that I took at the American Academy's Brain Health Day in Washington in September 2023. If you look here on the right side of the slide, you can see here the arrow, it says high income countries, and the colors describe for what the money of health is spent. So if you look at green, this is nursing. And you can see that in the high-income countries, a large number of nurses are financed because they are needed usually for maintenance of hospitals, for the care of older people. If you look at our region, which are the other two red arrows, Central and East Africa, you can see there's hardly any money invested in nurses, which means, or it can be presumed, that this force of nurses does not exist to which we could delegate. Next slide. Of course, it's also a matter of resources. And if you look at neurologists, they need a training of about 12 to 14 years. A nurse needs 2 to 3 years, others also 1 to 3 years. The relation I assumed for this calculation is that for each specialist, there would be about 5 nurses working in the field, and others, 2 or 3, this would be technicians, physiotherapists, and other fields. And if we look at our present situation, we would have, in the moment, if we calculate, we can estimate that the 1,600 neurologists will have a relation of 8,000 nurses and maybe 5,000 others. But if we have 14,000 neurologists, as we calculated, as we should have, we would need 70,000 nurses and 40,000 other healthcare workers. This, next, is of course quite an increase of costs. And if we calculate now the neurology costs with this rather scarce and limited number would be $25 million. If we have it to that amount, which would be 100,000, one would at least calculate 200 million, which is quite a lot. Another thing to consider, next, is that this is not only nurses and doctors, but the composition of spending also includes pharmacies or pharmaceutical drugs, administration, which is important, and quite a number of drugs goes also to dental services and emergency medicine. Next slide. So producing this large number of people, which is necessary, will produce an avalanche of costs. And of course, we have to assume that there will be a shift on conflict with other resources, as some of the resources that we will be using will have to be taken from somewhere else. Next. So another point to illustrate the problem is, if you look at the supermarket logistics, we have needs. And if you go to a supermarket, you have needs that can be acute, they can be important, they can be permanent, they can be rare, aranti. And if you look at the supermarket, and we all know supermarkets, they're all logistically arranged. In the beginning, you have something fresh, acute. If you move along, you have more enduring material, and you always have special offers to seduce you to buy something else. Next. So if we convert this to our work with neurology, we have to avoid that we are attracted by acute activities and have to focus on stable, long-term and logistic aspects. Next one. For instance, a good example is that only recently heard a professor of a specialty say that taking drugs to Africa and bringing them yourself to some country would solve some problem. It doesn't, because they need to be registered, they need to be prescribed, and it may be good to one-time effect, but it's not sustainable. Next. So acute terming and long-term planning is an important aspect. Next, please.
Andy Lishka.
The next one, please. Avanti, yes. And now I come to the next example that's very thoughtful and will bring us many ideas. So if you look at this, these are the essential medicines. And I'm sure that you were able to look at the essential medicines yourself. I have to say the good news, neurology has now levetiracetam in the essential medicine list, rituximab and cladribine for MS. Next. Avanti. And this concurs also with our work that I mentioned before, the needs registry. And I will point out a few things that are important for our considerations. Next slide. So the first one is we have this essential list of medicines, which undergoes a very strict selection. It also has a commission in, I think, in Italy, who suggests some drugs, others not. All of them should be cheap, and all of them should be generics. Next one. But it's not only the essential medicines list that you can see on the list. You also have to consider if in a given country the medicine is registered, if it ends up in the standard treatment guidelines, if there is a supply chain, what the quality is like, and definitely if persons are able to buy the drug. So this is called affordability. Next slide. And this is an example on how strict the WHO selects the parts of the EML. You can see here drugs that are recommended and drugs that are not recommended. And for neurology, for instance, clonazepam is not recommended anymore. Donepezil, which is distributed worldwide for dementia, is not recommended. Ocrelizumab for MS is not recommended. Next slide. So health financing also not only depends on affordability, but it depends also on fair pricing. Next slide. And this health financing is this is a slide from the WHO World Federation Atlas a few years ago, who calculated how many countries had a special health budget for neurology. And you can see here this were in some countries very few. So putting neurology into health budgets is one of our tasks. Next. Now, affordability sounds a weak argument, but it isn't. For instance, there are some tracer examples. Ethiopia, for instance, for carbamazepine, 200 tablets cost 30 days work. So quite clearly, this would not be affordable. For Nigeria and Ghana, a 30-day supply of levodopa was unaffordable. And this goes on and on. So this means that the drugs, even they are generics, once they're distributed, the affordability is not always guaranteed. Next one. This also shows that in some countries like rural and urban Ghana, some drugs are of course available in cities. These are the blue ones, and very difficult to achieve in rural areas, which is in such a large area as Africa, a very important problem. Next slide. So drugs may be available, but it may not be reached because the support chain doesn't work, or drugs are there, but they are not affordable because of wages and because of lowest paid of unskilled workers. Next. So another thing that I learned is that there's also something that's called stock out duration. That means the best prescription does not work if there's not enough stock in the logistic system. And this shows on the right side examples of how difficult sometimes the effects of these stockouts are. Avanti. Now I want to bring your attention to this slide. This is just going to be published this week in World Neurology, where we have an eminent group reporting on the essential medicines list. And they took out Kenya, Tanzania, and Uganda and compared medicines. So EML means those that are in the WHO drug, and you can see several of the WHO drugs are not registered in the country. And this is also in particular very visible for migraine, where in Kenya, none of them is registered. In Tanzania, 2 of 5 are registered. And in Uganda, there are more registered. And this is the same for the anticonvulsants, where in some countries, the drugs recommended by the WHO are not registered. However, other drugs are registered that do not at all correspond or relate to the essential medicines list, and maybe they are also for commercial reasons. So my expectation when I went to this meeting of the essential medicines was there would be many complaints. What was not on the list, but it was more the logistics. Avanti. And what I learned, and I think we can learn that for the distribution of neurologists in Africa too, procurement means to import, to get the goods, or in that case drugs, you have to import them, you have to pay them. That's quite clear. But one big obstacle in Africa is that not all drugs are registered that appear. And not registered, giving a non-registered drug is an illegal thing that we cannot eliminate. So this has to be solved. There is a problem is distribution. And of course, one big problem is, as there are few doctors and even less neurologists, there's no one who prescribes the drug. So prescription practices need to be changed, and this could be something where we could include primary care. And of course, affordability is an important point, and I've mentioned that before. Next one. With that, I end. And I hope I gave you a short overview on the WFN as a global charity, that we have in our main aim education. We also do publications and try to foster that. We are very concerned with the north-south distribution. I have spoken about life expectancy, the number of neurologists, logistics, and the essential medicines list. And I hope I was provocative enough in my talk to stimulate our thoughts on how to proceed with our efforts. Thank you very much, and thank you for listening.